Hi, I'm Linda Stein Gold. I'm from Henry Ford Hospital in Detroit.
And I'm Josh Zeichner from Mount Sinai Hospital in New York City.
We're both on a panel giving some updates on what's new in acne and rosacea. And I talked about 3 pearls for rosacea. The first is think about topical ivermectin for ocular rosacea. There was a really interesting case report that showed good efficacy. The second tip was combination therapy generally works faster and more completely than monotherapy for rosacea. So think about, we had 2 studies, one with ivermectin and brimonidine, showing that starting the 2 at the same time actually had better efficacy on even the papules and the pustules. And oral submicrobial dose doxycycline and ivermectin actually had a more complete response in terms of getting patients to completely clear than ivermectin alone. And my third tip was regarding research. You know, we have a lot of new drugs in the pipeline. The first one is a topical minocycline foam that shows really nice promise. The second one is a topical benzoyl peroxide. I know you wouldn't normally think about benzoyl peroxide, but it has been shown to be efficacious and well tolerated. And the third is a low-dose minocycline, and that also showed good promise, and we'll have to see where these go.
It's an exciting time for acne and rosacea.
It is, and you, Josh?
Yeah, so I gave a pearl on treating special populations of patients with isotretinoin. So more and more in our office, we're seeing female to male transgendered patients who are on masculinizing testosterone. And testosterone actually promotes acne production, and oftentimes these patients are unresponsive to traditional topicals and oral antibiotics. So we need to enroll them into the iPledge program for treatment with isotretinoin. But the question is, are these patients considered females of childbearing potential or not? And I reviewed the data, and as it turns out, despite being on testosterone therapy, these patients can become pregnant, and they should be considered females of childbearing potential. So oral medications that have oral hormonal contraceptions, I should say, are really not appropriate in these patients because they counteract the testosterone therapy. So you can consider a copper IUD or think about speaking to your patient about abstinence. But I think it's a really important topic for all of us to think about right now in treating these patients.